Okay, everyone. Well, welcome. Thank you for joining us during this lunchtime. Again, we're here to share a discussion with all of you, share some of our experience. This presentation is titled An Experience, Interdisciplinary Health System Strengthening, Neurosurgery and Neurorehabilitation Working Together. A few key things to know. Today's session is recorded and will be posted later on. We also will have a question and answer session at the end. And both people in the room and our attendees online are welcome to join. So let's just go ahead and begin. So so we're here today to talk to you about the importance of our interdisciplinary work. Something that has become obvious to us and we really have taken a lot of time to invest in is the fact that there's two areas of healthcare that are really important to consider when you're thinking about the patient experience. That's the medical side, all the medical care that a patient receives. But then on the other side of that is rehabilitation. It's a side of healthcare that often gets forgotten when we think about health system strengthening. So we're here to share our experience, what we've learned, and some of our future plans. Today, joining us, we have multiple speakers that I'm excited to have in person and online. Dr. David Kitya from Imbarara University of Science and Technology in Uganda. Dr. Michael Haglin from here at Duke University. Professor Herman Kazibwe is also online. He is also from Imbarara University of Science and Technology. Ms. Knight Agwangere is also from Imbarara. Dr. Etienne Enge is from Cameroon, and then I'll also be speaking. And just a quick overview of our presentation, we're going to start with explaining some information about neurosurgery in Uganda, some of the global work that has taken place to help develop the system of neurosurgery in Uganda. We're going to briefly just introduce neurorehabilitation to everyone, as we understand it may not be something that everyone's very familiar with. And we'll talk about the current status in Uganda. We'll share some continental similarities across Africa, and then talk about the opportunities for collaboration that we've identified both internationally and interprofessionally. So our first speaker, I'm going to turn it over to Dr. David Kitya. He is the head neurosurgeon at Imbarara University of Science and Technology, Imbarara Regional Referral Hospital. Dr. Kitya, I welcome you to speak, and just let me know when you want me to advance the slides, please. Dr. Kitya, if you can hear us, you're on mute.
Hello, good morning, good evening. Thank you for having me, and I'm happy to be with you here. I want to talk about several issues in neurosurgery in Uganda and at Imbarara. I will start with the traumatic brain injury. It's a big problem to neurosurgery and the patients. The incidences are high and much higher in the low and medium income countries. So at Imbarara, we admit over 1,000 cases per year. In fact, it's the commonest cause of admission in emergency ward. And the problem is that we don't have facilities to treat the conditions. So there is a low availability and administration of emergency and critical care services. So the instances are many, are high, and the complications are many. Stroke is also a common problem. There are two types. There is ischemic stroke and hemorrhagic stroke. Ischemic stroke is the commonest, and it commonly, the incidences are high and are increasing, especially in urban areas. And the causes are mainly hypertension, lifestyle problems like drinking, and in the obese. And these patients need also emergency services, which are not readily available in our country. Hydrocephalus is a common problem. Incidences are high, and in the low and medium income countries, the commonest problem is actually infection. And early treatment and with ETV or BP shunting gives good results. But many times, because the resources are not available, we cannot get it. Next slide. Epilepsy is also a common problem in Uganda, and the causes are many, like a trauma, infection, and space-occupying lesions. And the problem that many times patients come late because of stigmata. They don't want to expose their children, common children, they don't expose their children, or even adults don't come. And poor resources lead to poor care and poor outcomes. Next slide. Spina bifida is another problem in the low and medium income countries. The causes are mainly environmental, food contamination, drugs, and the like. The commonest one, called myelomeningocele, needs early closure, and it needs lifelong treatment if you want to avoid complications. So you need things like intermittent clinical sterilization and rehabilitation. It needs many other specialists to engage in the management. The problem is preventable by mainly food fortification with folic acid. Next slide. That map shows southwestern Uganda, and it shows the dark green is where most of our patients come from. So it clearly tells you that the causes are linked to the environment. Next slide. Spinal cord injury is a common problem, a neglected problem in Uganda because of low level of awareness among even health care providers. So patients are referred late, and the treatment is difficult because there are no resources where its management needs good surgery with plates and screws and many other processes which we do not have. And rehabilitation is lifelong because if you don't do that, the complication will kill the patient. They will die from pressure sores, they will die from urinary tract infection. So rehabilitation is very important in this condition. Next. Intracranial tumors are also common in this part of the world. Last year, between 2016 and 2024, we admitted over 377 cases, and we operated on over 270 cases. The lesion is more prevalent in adults, but affects also children. The commonest forms like medulloblastoma and astrocytoma are common in adults and more prevalent in females. So it needs early treatment, but many times patients come late when surgery cannot even be performed because they have come late. And after surgery, they need rehabilitation and chemotherapy. The picture shows that this condition affects the whole spectrum of people, children, adults, and the youth. If you talk about the youth, actually they are more affected by the road traffic accidents. So it can affect actually the productivity of a country because it's the younger ones who are the breadwinners, and they're maimed and they're killed, and so production goes down. The history of neurosurgery in Uganda started by Giovanni Kiriabwire in the late 60s, 1960s. And you can see how we have progressed. We are now a population of 30 million people, over 30 million people, but there are only, in the year 2000, there are only 2 neurosurgeons with one hospital offering public hospital offering neurosurgical services. Today, the situation is different. We've got two hospitals, Mbarara and Mulago. But then the problem, lack of diagnosis services, lack of personnel to do the surgeries, and inadequate facilities for training. But international collaborations like the DGNN has actually helped, and we see that the numbers now have improved. There are about 21 neurosurgeons. That picture shows our residents and the consultants participating in treating patients in neurosurgery in Uganda. Next slide. So current status, there are now 21 neurosurgeons, and the goal is to have about 30 by 2030. And I can assure you we have moved on, because now we have 21, and there are more than 12 in training between Mbarara and Mulago. And you can see that the ratio of neurosurgeons to patients in Uganda is very low. WHO recommends 1 per 100,000 people, but ours is 1 per 2.6 million. So we don't even beat the 1 per 200,000 recommended for low and medium income countries. There are 2 public hospitals. There are somehow improved diagnostic services, because there are CT scan facilities at every regional hospital. But of course, still there's no equity, because the infrastructure is low and the personnel is also low. Next. The map shows the places where neurosurgery takes place in Mbarara, in Kampala, and in Mbale. So there are only 3 towns, but there are 4 hospitals now offering services. There is no representation at all in northern Uganda, and that's a vast area. It shows the landscape of training I have referred to. There are 2 parallel programs in the country now, assisted by DGNN. You can pursue Masters of Medicine in neurosurgery, or you can pursue the fellowship in the College of Surgeons of East and Central Africa. So you need to have your bachelor's degree in medicine, and then you enroll in any of those. For the fellowship, you need to pass through membership, or you can go to fellowship through training in master's program of general surgery. The course requires 6 years of training. Next slide.
Thank you so much. All right, thank you so much. So I'm going to turn it over now to Dr. Michael Haglund, who's going to talk about global partnership in neurosurgery.
Thank you.
Thank you very much.
Vera, it's a pleasure to be here. So I serve as the division chief for the Division of Global Neurosurgery Neurology, and I'll tell you a little bit about that. Paul Farmer, one of our heroes, the idea that some lives matter less than others is what's wrong with the world. It's so true, especially in these low middle income countries. If you look at the Lancet Commission, it's a 10-year anniversary of Lancet Commission on Global Surgery. They talked about 5 billion people not having access to proper surgical care, a need for 2.2 million more surgeons, obstetricians, anesthesiologists type thing. And you can see down there in the very lower part in sub-Saharan Africa where the greatest need is. When we started in 2007, if you looked at the world population and set the US to 1.0, you can see India and China are obviously much bigger. But if you look at Africa and now look at the number of just physicians, not neurosurgeons, physicians, the sub-Saharan Africa falls into the Atlantic and the Indian Ocean. If you look at the number of neurosurgeons that were there in the United States at that time, 3,600. In all of Africa on the continent, there was 585. The problem with that was the distribution. If you looked at the distribution, there was 485 in Northern Africa, countries like Tunisia, Morocco, Egypt, and South Africa, leaving only 79 neurosurgeons for all of Western, Central, and Eastern Africa. To give you a feel, why Uganda? Well, this pastor came to my church in Raleigh in June of 2006 and told me I was going to go to Africa. And I said, well, pastor, you're on the wrong continent. I do my missionary work in Ecuador. And he goes, no, I think you're going to go. So we decided to go, and we found that they just didn't have anything. They were doing surgery like 1930s US. They got into the skull with a hand drill. They used a braided wire to cut the bone. You know, like when a little kid scrapes their knee, they put a piece of gauze on it to stop the bleeding. Here at Duke, we use this fancy little bipolar that passes a current to coagulate vessels. They would lay a piece of gauze in the brain and hope the bleeding stopped. The problem was, you compare Morocco to Uganda, Morocco, the same number of people, they had 171 neurosurgeons, they had 15 different neurosurgery sites, and they had 5 or 6 training centers. Uganda had 2 places, the National Referral Hospital in Kampala, the major city, and then out in Mbale, out in the middle of nowhere, Ben Wharf, this amazing neurosurgeon from Harvard, had built a children's hospital there, and they, at that time, probably had the best equipment available. So we came back from our first trip and found out they only had 1 neurosurgeon for 6 million people. They had no technology, nothing. They had 1 ventilator in the whole hospital, and that was up in the ICU. So during the 8 or 10-hour neurosurgery case, when they're taking out those big tumors, they would have to handbag the patients with like an bamboo bag to get them their anesthesia. And there was, you know, only 2 neurosurgery sites and no training program. So as the population grew rapidly, it was never going to get better. So we came up with this idea of sort of the 3 T's and an R, and I'm only going to talk about a few things today, but the technology. We started this Duke Global Health Plus program where we take used equipment from Duke that was working fine in my OR yesterday, but now is in the surplus store. And you take a $40,000 anesthesia machine and you depreciate it over 5 years, and it would go to the surplus store, and a liquidator would buy it for $600, and the next day it would be on an internet site to sell to veterinary clinics in the US or low middle income countries for $6,000. I said, well, if it's still working that well, we should keep that. And then we did this twinning thing where we brought neurosurgeons, ICU nurses, OR nurses, recovery room nurses, biomed engineers, anesthesiologists to Uganda. And as far as the technology transfer, over the period of time and 21 trips we've done, we've donated about 125 tons of medical equipment worth about $15 million. We've had great help from the Global Health Institute here. What's going on? And we've also had volunteers go with us. And so Duke has done that. We started a training program where we started with just 2 residents, and now we added 3 more. In this picture, you'll see Juliet Nikala, who's the first woman neurosurgeon in all of Uganda. She went off and did a pediatric neurosurgery fellowship at Toronto Sick Children's, probably one of the most outstanding surgeons in all of East Africa. Now, over the time we've had, they started with 5 neurosurgeons in 2007. Dr. Kitcha kind of covered this. We now have 16 graduates, so now there's 20 neurosurgeons in Uganda. There's we have 24 more in the training program right now. Our goal, Dr. Kitcha had a small goal. We have a big goal. We're going to get to 63 by 2030. And that'll really help significantly. So if you look at when we started, there was this, and then Dr. Kitcha started the program in Mbarara. And then we added another training program at Mango Hospital in Kampala. And the goal is over the next 4 or 5 years, if we can, to start up about another 3 or 4 sites. Those neurosurgeons will then train general surgeons how to do simple neurosurgery, a depressed skull fracture, something they could do in their local general hospital. And they'll come and work with our neurosurgeons for like 3 months, learn how not just to do the surgery, but also how to take care of the patients afterwards. So now we have 63 neurosurgeons for 62 million. That's making a small dent. But if we add all those general surgeons, now we'll have over 400 neurosurgery trauma surgeons. And now the number will be 1 to about 147,000, which is right in line with what the WHO talks about. So if you look at it now, what we're looking for in 2030 to get to 1 to 147,000, which is just like Morocco. And thanks to Dr. Kitch's program and the program we started originally, and now another program, there'll be 3 training programs in Uganda and multiple sites. Now, 10 years ago, we celebrated our 10-year anniversary just this last October. We started the Division of Global Neurosurgery Neurology. It was the first in the country where we would focus on global neurosurgery and neurology. And there's 2 of us, 2 master students in global health, Tony Fuller and Tu Tran. They were my 2 people. We slowly grew this through our camps, through the Bass Foundation, through the training program, and now our group looks like this. One of the things that's been key is we found out was we did a deep dive on our success rate after we'd been there a couple of years. And Tony Fuller did his master's thesis, and he calls me from there. He went through over 2,000 charts, and he called me and said, well, the patients are doing worse now than before you came. And I go, what? Well, it turns out we were actually, rather than just taking a little biopsy and closing the scalp, and the patients did fine and then died shortly thereafter. We were doing the whole surgery, but the big miss was after surgery. They went to the floor and they had complications because there was no rehabilitation. There was no good nursing care. And so what happened was, for instance, we had a patient who I did a really nice brain tumor on, one of those huge brain tumors. She had seizures before. We sent her out on epilepsy medications afterwards, and 6 weeks later, she died from status epilepticus because she couldn't get her medications. We've had other patients have really poor outcomes because they never got a discharge planning or a rehab setup. And so we've made this an academic effort. We've published over 125 papers. This slide right here shows that almost 45% of the papers we've published out of those 125 have been either a Ugandan first author or a Ugandan senior author. So they're very involved in our research effort. And then I'll just finish with this. This is Mbarara Hospital. You see the parking lot where the cars are. We just need $8 million, and we're going to replace it with a 4-story standalone neurosurgery hospital that will have neurosurgery ICU, high dependency floor beds. But the key things that'll be in there that go with the talks today is there'll be almost a whole floor dedicated to rehabilitation. So those patients, as they move from the ICU on the 4th floor down to the 3rd floor, will go to the 2nd floor and have rehabilitation and get proper discharge planning. So the outcomes we get from a great surgery that failed because there's no discharge planning will be able to be done, in that facility. So we started a non-for-profit NeuroHope Africa, and we're going to try to raise just $8 million to build this hospital over the next 4 or 5 years is our vision. And I think that'll make a huge impact on what goes on in Uganda. Thank you.
Thank you very much. All right, so we're going to continue. So I do want to, as we continue the presentation, myself and Dr. Herman Kazibwe are going to present about neurologic rehab. But I just want to pause and thank you, Dr. Haglund, also for making a key point. There's a difference between successful surgery and successful patient outcomes. And that'll be one of the messages we circle back to. So one of the biggest things that have been learned is that the surgery is extremely important, and the people who do it, the amount of effort and passion they put into it's amazing. And that's the life-saving effort. But getting that's not the only experience for the patient. The patient experience is something that involves multiple people. So we're going to now try to just give you a quick overview of what neurologic rehab is. Myself, I'm a doctor of physiotherapy. And also Professor Herman Kazibwe, who is the head of physiotherapy department at Mbarara University of Science and Technology. And so I think Herman is here. So I will speak a little first and then pass the microphone to Professor Kazibwe. So rehab. First misconception is that rehab is physical therapy and physical therapy is rehab. That's physical therapy or physiotherapy as it's known abroad is a very big part of rehab. I would think of this as what we do for a patient to help them return to their physical function, to their mobility, particularly in neurologic rehab. How do they get back around their home? How do they get back around their community? And how do they do it safely, appropriately, and how do they do it as independently as possible? So think about someone who maybe needs me to help them. Maybe I have to do about 50% of the work to help them physically move. And by the time they finish seeing me, hopefully they're doing it independently, maybe with some kind of assistive device. Occupational therapy is another service. And this usually, quite often, occupational therapists work with activities of daily living, self-care. So think about how you just get up in the morning and take care of yourself, brush your teeth, feed yourself, dress yourself. All of those basic things that when you've had a neurologic injury or disease, you often end up relying on someone else to help you do. Speech and language therapy, so how you communicate. And I should say some things cross over. So occupational therapy and speech therapy often work with cognitive issues. You might know someone who has something like aphasia, trouble speaking in some way. They also work with swallowing, so to make sure we prevent things like aspiration. Neuropsychology, particularly think about after traumatic brain injury. There's a lot of patients that experience depression or mood disorders. They have trouble regulating their behavior. And so neuropsychology steps in to help work with that. And then there's many other rehabilitation providers that are part of the team as well. You have your physiatrist who are still attending to the medical needs. Even though at this point the patient is perhaps medically stable, they still may have medical needs that a physiatrist would help address. You have prosthetics and orthotics who are helping with different types of splints and braces that a person may need. And then audiology and optometry are even considered as a part of this group as they support some of the needs of the patient as they recover. So it's a large team. When we say rehab, it's not just one type of profession. It's a whole team. And there's also many levels of care that this exists in. So it's not as simple as just here's your rehab department. When I say acute care in this figure, it really covers everything from the ICU to the step downs, anywhere in the hospital. And then a lot of patients may go home, but there's all of these intermediary care that may happen. Some patients end up going to long-term care because they have high needs for a long period of time. But then we have these other levels of care. Inpatient rehab, a person may go stay somewhere for 1 week to like a month, maybe. And they're getting therapy from all of those different providers for about 3 hours a day. It's basically boot camp, as my patients tend to learn very quickly. And that's with the goal of getting them back in their home safe. That's not even the end of their journey. Subacute care is often when a person needs a little longer than that 1 month. They need rehab, but it might take them quite a bit longer. They could be in there for months. They could be in there for years. Home health comes to the home for a short period of time, but typically people then advance to outpatient. And we can be seeing patients for 2 years, 3 years. And as Dr. Kittia mentioned, for some people, it's lifelong. So this isn't just like a one-time you meet person, see them for a little while and it's done. We play a very big role in the life of a lot of these patients. And I'm not going to go over all the evidence of this, but I think there's sometimes a misconception that it's nice to have rehab if you can, but the evidence is overwhelming. There's meta-analyses, systematic reviews, randomized control trials for all of the services, just to show the effectiveness of their interventions. And those things, that means working on a person's gait or their walking, their activities of daily living. As I mentioned, arm mobility, just being able to feed yourself and take care of yourself. Balance, communication, so all of the things that you see listed here that are essential to our daily lives. Rehab is very effective in helping a person get back to those functions. So I'm going to turn it over now. Professor Kazibwe, I think you were going to continue talking about a few things as well.
Thanks very much. Good morning, good evening to everyone. I would start with some of the equipment we commonly use in rehabilitation. And these equipment fall into the categories of the multidisciplinary team she has already elaborated. We have those that protect the injured parts. We refer to as orthotics or braces. Then we have those that we usually use for training, flexibility, strength, plus cardiopulmonary endurance. We also have those that we commonly use for training gait, especially for patients who have issues with gait. Then our other colleagues, the occupational therapists, the speech and language therapists also have certain devices that they also use for training activities, occupational or activities of daily living, also training speech, especially for patients who have lost speech. Now, in Mbarara here, we have a workshop that is manufacturing some of these equipment, especially the braces. Most of the braces are manufactured locally. So that one gives us a very good leverage when it comes to managing these patients requiring some of these devices. However, there are some of these equipments that we sometimes cannot acquire locally, especially those that are used by the occupational therapists and some that are used by the speech and language. Next. Now, most of our patients, both inpatients and outpatients, here in Uganda, we commonly use caregivers or parents of these patients to help us, especially with rehabilitation, especially when we give them formal training, some bit of training, especially post-discharge. But then one of the biggest challenges we found is that most of these patients after discharge, most of these caregivers are the ones that are supposed to take care of these patients in all globally, looking at the social aspect, financial aspect, plus other areas. So you find that a caretaker will be at home, is the one responsible for taking care of the foods, cleaning the house, advising the patient on the medication to take, then also providing the medications at the right time. So sometimes some of these caregivers are overwhelmed by the amount of roles that they have. And then we found out that they, in the end, have limited amount of time that they usually devote to patients. And by the time these patients are brought back to hospital, they have developed some complications. So our plan is to see how do we help these people be able to take on some of those roles, but at the same time, take care of the patient. Of course, the patient is one of the main aspects of their work. So we are working out a mechanism to see that we engage them more and then give them more of the basic techniques that they can be used at home so that they can be our representative, because most of these patients, because of the socioeconomic status, they cannot make it every day or every after the other day to the hospital. We found out that in the hospital where we are working, we are mainly using the multidisciplinary team working, where each of the professions is consulted, especially when you have a patient, let's say on the ward, comes in, gives in his input, and then we've seen that if we brace in the interdisciplinary team, it will give more leverage. We found it is very beneficial, especially when it comes to discharge planning of these patients. We need to know the environment where some of our patients are going. And also we need to plan what should we do in order to follow up some of these patients, especially when it comes to assessing the function, outcomes of our treatment, because our major goal is to see that at least this patient is functional and independent as much as possible. So we needed to find out how much function have they acquired during this period when they are off hospital. So we found out that it's very important to have a combination of the two, the multidisciplinary and then the interdisciplinary, where we involve the patient and the caretakers when it comes to planning the discharge and then the treatment after leaving the hospital.
Thank you very much, Herman. I appreciate your time, and we'll be speaking with you again shortly. Right now, I'm going to turn it over to Madam Knight at Wangeria, who is a senior physiotherapist at Embarara Regional Referral Hospital. She is the president of the Ugandan Association of Physiotherapy and a former member of one of our Bass Connections groups. So we've been lucky to know her for quite some time. Knight, just let me know when you'd like me to turn the slides.
Thank you very much, Dr. Kira, for the opportunity and invitation. Good evening, good afternoon, good morning, wherever you're following us from. And so I'm going to talk about the rehabilitation providers and how the situation is at the moment, the challenges, but also the points where we would gain some support. So at the moment, when we talk about general workforce, because in the area of rehabilitation, we do not have specialization at the moment. We don't have specialization training in the country. We have a few specialists who go out of the country and train from there. So the few people who are registered, as you can see, only about 736 physiotherapists and occupational therapists and just about 87 speech and language therapists serve this population in Uganda. As of 2023, Uganda is up to 48 million people, and we are looking at just less than 1,000 people serving that population in terms of rehabilitation. And this is mainly because we also have a limited number of training programs, because at the moment, we have only 4 diploma training programs for all rehabilitation professionals. We have 2 diploma training programs for physiotherapists, 1 for orthopedic technologists or the prosthetists and orthotists, OP and Os, as many may call them, and then 1 for occupational therapists. Now, it is unfortunate that the latter 2 programs I've mentioned still do not have bachelor's training in the country. And the 4 training programs we have at bachelor's level, 3 of them are for physiotherapists and only 1 for speech and language therapists. So we still have low numbers because the training is also still low. Next. And when we go to still on the workforce and where the services can be found, according to the health facilities we have in the country, starting from the low health facility or at the village level, we see that there are no rehabilitation services available. These are public health facilities that offer the healthcare services in the country. And we know that in Uganda, there are no user fees on health services, okay, publicly, but at some point, patients will have to meet costs of transport and even some consumables in the hospital. But talking about rehabilitation, it's only at the secondary care level, which is a health center for a general hospital, regional referral hospital like Mbarara, and then national hospitals like Mulago and other places that we find rehabilitation professionals. We still do not have them at primary healthcare level or even the lower centers, and that continues to render the service inaccessible to most of the people in Uganda. Next. A study that was done about a few years ago indicated this was mapping out like the capacity of rehabilitation professionals, and it was done in the southwestern region where Mbarara belongs as well, and a few other hospitals. And this was found that the maximum number of people offering rehabilitation services was between 5 and 4. And really 5 was for the orthopedic technologists, OP and Os, and the highest place the places that had the highest number, which was Mbarara according to the map, had only 4 physiotherapists and about 3 occupational therapists. Now, this is a hospital that serves up to 4 million people, and with super specializations at different levels in different specializations, neurosurgery and other places. Now, we have general physiotherapists, but we also have just 4 of them in such a big area. That alone shows that the need for rehabilitation cannot be met by the current workforce. And when we looked at the different general hospitals, we have 10 of them and only 4 of them had physiotherapists. So the rest, the other 6 general hospitals didn't have. Only 3 of them had occupational therapists and 2 had P&Os. Now, this also shows that we do not have SLTs or speech and language therapists in this area working for the government hospitals. And this means that most of our patients who would really benefit from speech or communication or swallowing rehabilitation actually do not access it. Next slide. And then when we talk about the available infrastructure at the moment in public health facilities, we only have acute care, and we offer this in ICU, like ICU care, HDU. Luckily, we have HDU at Mbarara at the moment, and it's been a very good thing. I'm sure Professor Chitia can testify to that. And we only offer at that level. And then at the outpatient services, where patients really come back for review and come and get physiotherapy. But this is still very limited because for outpatients, we can only offer service on a few days, maybe once a week, or at most twice. As we have seen the number of PTs available, this makes it very difficult for all patients who need rehabilitation. Even if they were able to turn up for outpatient services, they would still not get like the best services because the number of providers is very limited. And we still lack care at inpatient rehab. Hopefully, as Dr. Hagland has said, maybe when we have the new building, we'll have this service in place, and I'm sure a lot will improve. And we don't have community-based rehabilitation. And these other areas, as they are highlighted a bit darker, for community-based rehabilitation, really would want to settle someone who has had a disability or has had severe trauma back into the community. How do they fit? How do they manage at home? How do they engage in the wider community? How do they get more functional? Or how can they actually be helped to change either profession, depending on whatever limitations they've acquired following the injury? Next. And so as we can see from the statistics, there is increasing rate of disability everywhere. And actually, there is also the aging population, which is a global problem that is also affecting Uganda. So we see that over 40% of the disabilities worldwide and also in Uganda are among the older adults, and those are people aged 65 and above. But as we have seen from the start of the presentation, disability affects almost everyone. Now, challenges that we meet is that disability grows at a faster rate, while the rehabilitation services are stunted for most of the time or growing very, very slowly. And that's where we need policymakers, that's where we need research, because we have limited research in rehabilitation. Thanks to DGNN, now we can talk about some research in rehab, but it's really been limited. And then we need more policymakers thinking about rehabilitation. We have a strategic plan that has been worked on, and it is just waiting for implementation. But we are looking at how do we meet the WHO Rehabilitation 2030 call to action. We are still limited, and as we can see, this is just a snapshot of the restructuring for workforce in the regional referral hospitals. We're looking at this, and we wanted to compare how rehabilitation fares versus the other health services. We saw that they were trying to meet the number of, increase the number of professionals serving the population that has grown, but there was a wide discrepancy, as we can see that most of the other specialists were increased by over 3 times and so. But when you look at physiotherapy and occupational therapies, they are just increased by a small number. So this means that policy-wise, the rehabilitation sector is not being prioritized, and that shows that we are going to get more people less functional, more people less economically productive, and then we will not be able to fight poverty or even improve the outcomes of the services already given. Next.
Right, thank you so much for your presentation. I'm going to turn it over to Dr. Etienne Nge very quickly, who is a cardiac rehabilitation specialist from Cameroon. And he does a lot of international work on the continental level, including leading the African Rehabilitation Network. Dr. Etienne, let me turn it over to you, please.
Thank you very much, Akira, for having me. Greetings to everyone, and thank you all for the invitation. I will be talking briefly about the regulation of rehab professional workforce and prioritization funding on the African continent. I really want to actually say congratulations to the previous speakers, because they've actually talked on exactly what is the reflection of rehabilitation in most African countries. It's actually a struggle in the sense that, yes, it is lacking and it is not actually very much received. Rehabilitation on the African continent in terms of workforce really is often assumed to be physiotherapy, because that is the predominant rehabilitation professionals that are found on the continent. Recently, we have the study which 80% of most of it, the respondents were only physiotherapy. So when we talk about regulation of these different rehabilitation professionals, which is predominantly physiotherapy, and most often the second in ranking is always occupational therapies, and then speech and language therapies, with most of those which we've seen in the previous presentation lacking audiologists, physiatrists, and the rest. We realize that in the African settings, they don't have full control of the profession, and it is not fully developed. My previous speaker have just mentioned that, yes, we don't have the different specialty. And this is very common across many African nations, because these rehabilitation professional bodies, which are members of this international organization, like we can see here, 27 for African countries, for physio, and then 17 for World Federation of Occupational Therapists. Irrespective of being members in this international organization, the functional body don't really have that regulatory capacity within the respective nation. And my previous speaker also mentioned about the lack of research to identify some of these areas. I often say, if these regulatory bodies have to be effective, they need more research, they need more clinical, they need more training, and they need to consider their leadership. These are really, like, we do refer to them as core pillar of the profession. And I think it's applied to most of the health profession generally. So with that, this has been very difficult to control and develop the profession within the respective African countries. Next slide, please. It's not purely just in more, I would say, hospital-based rehabilitation personnel, but it also reflects even in community-based rehab workers across the continent. You can see on the map here, we do, only 4 countries do have 200 to 400 members in the network of community-based rehabilitation for Africa, which doesn't really show much about how activities within the different regions. Next, please. Generally, following the Uganda, no, previous slide, please. the Uganda, my speaker have just shown, the numbers across all rehabilitation professionals are generally very low. And it is even very difficult to establish because the regulatory force or the regulatory bodies are not capable of really controlling and trying to develop the profession because they don't actively consider the 4 pillars which I've mentioned. How do we improve generally in terms of training for clinicals, research, leadership across these 4 pillars within the profession. So this makes it very difficult to know even the exact number of professionals or rehabilitation professionals within respective countries. Next slide, please. So you can see here, it's just data of different physiotherapy, the number of physiotherapy per 10,000 population across different African countries. And you can bear with me that only about 2 countries have more than or close to 2 physiotherapy per 10,000. Many countries, they don't have. And we are talking about physiotherapy, which we consider it to be actually the major rehabilitation workforce across the continent. Because if you're talking about speech and language therapies, these numbers can even come close to this. When you look at this number and compare to Europe, where you have at least close to 14 physiotherapy per 10,000 population, you realize that, yes, we are really, really low. So Africa as a whole is ranked to have 0.2 physiotherapy per 1,000, which is 64 times that which most European countries do have. Next slide, please. Yes, training. From the Uganda case study, we've seen that training is actually, we have few programs generally for the different rehabilitation workforces across the continent. And some countries don't have, at least physiotherapy is predominant or is the most, the highest, but we have many African countries that are actively not training either physiotherapy or any workforce, rehabilitation workforce in general. Next slide, please. So this is a figure actually showing the English-speaking countries training programs across the English-speaking countries in Africa. And you can bear with me that only Nigeria, only about 3 countries per this data shows that we have postgraduate programs. And we do still have diploma programs, and majority of all is BSc programs. So we need, if really we have to reinforce or improve our workforce, we do need actually a good number of postgraduate training programs. There is masters, where people can go into the different specialization, as well as into the research that can actually help in identifying some of the local problems and solutions within the different professions. Next slide, please. Yeah. Rehabilitation is an unfunded priority in most African nations. Why presently we are gaining a bit of political attention, we still have failed to actually receive adequate financial and human resource allocation, as Knight just mentioned. So we have it is quite difficult in terms of people enjoying the rehabilitation profession within many African countries. And this is because rehabilitation is viewed by some as a social program, whereas by little as a health program, in which case that comprehensive view of it, reintegrating people into the community or in the chronic phase, and then the acute phase, which will take place in the hospital, is not fully considered, and making it quite difficult to identify the different actors, because we need these different actors and people that can collaborate to actually look holistically about the rehabilitation areas and priorities within what is needed locally. So the objective for the organization to have more solutions to most of these problems, they need a research workforce. But funding generally within most of the African nations is a big problem. And irrespective of the African Union commissioning most of the nations to actually spend at least 1% of their gross national product on research and development, evaluation shows that it's still below 1%. So this is quite imperative that for the different professionals to develop research that they can use to actually convince and engage the policymakers, because it's not just a talk, but we have to actually demonstrate our impact as well. And that's why the different pillars, they are quite important. Thank you very much for this opportunity to share my thoughts.
Thank you. And so I know our time is kind of running short and up. So I want to thank all of the speakers. We do have a few other slides. And Madam Knight and Professor Herman, I'm just going to summarize those slides really quickly for everyone as kind of a closing statement. So I hope we've kind of painted a picture for you all here that there's a lot there. It's not just like I think people know of the iceberg on top, but there's a lot underneath when it comes to rehabilitation. And what work is still there to do to support all of the efforts. So we hear a lot in global development of healthcare systems of the medical side expanding. But as you can see, the rehab side is quite large and there's a lot of work to do. I'm going to just 20 seconds review the few slides we had left. We've realized that we need to collaborate at the hospital level. So that means working together to increase rehab visibility, not only to patients and caregivers, but to other providers so that there's more interdisciplinary care. And the camps that Dr. Haglund and Duke has put on in the past has been a great opportunity to do that. At the collaboration at the academic level, we have research that we're doing together to, again, really strengthen that multidisciplinary, interdisciplinary care. As well as work on our observation of patient outcomes. So again, trying to get away from just successful surgery, but observe successful patient outcomes. One of those is the discharge planning tool that we're working on, which Professor Herman had mentioned earlier. And then finally, and we've had some international student teams supported by Bass Connections. And then finally at the national level to continue working with the association so that we're not just creating more of a rehab workforce, we're making sure that they're absorbed into the actual healthcare system. So that's my 20-second review. And like I said, the big takeaway is that there's a difference between, a successful surgery and a successful patient outcome. That interdisciplinary efforts are extremely important in order to do that. We can't grow in silos. We have to grow together. And as you can see, there's a lot of work to be done, but it is possible. Just viewing what happened with neurosurgery alone, there's really no reason why we can't also have neurorehabilitation and the entire rehabilitation system strengthened as well. So that's my quick overview of the last few slides. Thank you all so much for today. There is supposed to be a question and answer right now. I know we're at our time, so I may ask our organizers how they would like to proceed.
I think if there's one, you could do one in the room question if there is one, but no online question.
Great. Is there any question or feedback or comment? I know we are at our time.
I just appreciate the aftercare You guys mentioned the reasons why it's necessary, especially the deaths, something that someone not getting medication. I just really appreciate that that's in motion, and I hope you get that 800 million, how much is it?
8 million.
Yeah. How are you gonna work on that?
We're gonna trust that, have faith that we can raise the money, and we're connecting with people we know and people that have deeper pockets than me or the institution. We're having to do it outside of the health system just because the health system doesn't pay for building buildings in other countries, you know, kind of thing. So we're doing it outside. But obviously the foundation for all that is DGNN and the trainees and the rehab and all the stuff we're putting together, like Cures Groups has a big impact on what's going to happen when we do the final plans. There's a not-for-profit Build Health International that builds hospitals in low middle income countries. In fact, they built a COVID hospital on the Mbarara campus. So they're very familiar. The government's already given us the land in that parking lot to build the building there. We have a nice fly through that I don't have time to show, but we're starting. I mean, I'd say we've raised our first $100,000. We only have to get about 80 more of those dollars, and we're there. But we've got our first pledge for 100,000, but we need obviously a lot more. We need about 1.6 million this year to break ground and start the first floor, and then the last 2 million of that aid is actually putting the people, the equipment, and everything in the hospital. So it's about 6 million to have a fully functional building that's empty.
Yeah.
And then
Foundation, a good start.
then we have to do the rest.
And I just want to add to that, foundation's a good start. So this is amazing work, but the work starts now in having the workforce ready, having, you know, the people in place, having, as Knight mentioned, the inpatient rehab ready to go, the interdisciplinary care, all of that has to start now as well.
Thank you, guys.
Thank you all so much.
Thank you.
Thank you to all of our speakers. I don't know if anyone had any final comment they wanted to make, but thank you so much for joining. I'll send my thank you to each of you individually as well. Thank you so much, Knight. Thank you so much, Herman. Thank you so much, Etienne. And thank you so much, Dr. Kitia.
Thank you, too.
Thank you.
Thank you very much for inviting us.
Thank you for being here. Thank you for all your time work.